I'm Molly Flower. This Pecha Kucha is the second in a series on aneurysmal subarachnoid hemorrhage, and we're focusing this time on general ICU management. Fast Hug in Bed or Danish Bugfest are useful acronyms to help remember important and easily missed housekeeping issues for all ICU patients. However, a few topics warrant specific mention. First up, glycemic control. Hyperglycemia is associated with poor neurological outcomes in animal and human models of ischemic brain injury. Hypoglycemia is obviously bad for any brain, let alone one that's already compromised, such as following aneurysmal subarachnoid hemorrhage. There's limited evidence that tighter glycemic control may improve neurological outcomes, but the risks of dangerous hypoglycemia with Leuven targets have made neurointensivists too nervous to try this for now. Even normal glucose levels can be associated with brain energy, metabolic crises, and LP ratio elevation in patients with poor grade subarach. 6 to 10 is where we generally shoot for now, but with continuous glucose monitoring ever nearer, this is an area for future research. Anemia occurs in 40 to 50% of patients following aneurysmal subarachnoid hemorrhage and develops after a mean of 3 days. The ideal hemoglobin target is controversial. Potentially impaired oxygen delivery could cause secondary brain injury, but this must be weighed against the risks of blood transfusion. Data from prospective registries suggest that higher HB values are associated with improved outcomes following aneurysmal subarach and vice versa. There are lots of theoretical reasons to maintain a high hemoglobin following brain injury, and there's basic science evidence to suggest that injured brains lose the physiological compensatory vasodilation with anemia, resulting in neuronal hypoxia. But higher hemoglobin may predispose to vasospasm, and transfusion carries risks such as TRALI, TRIM, TACO, SIRS, AKI, and a raft of other great acronyms. TRIC was a long time ago in a different cohort, and now with leukodepleted blood of different ages potentially available, the jury's out on the ideal target and age of blood, most places aiming somewhere between 8 to 10 as a threshold. Incidence of DVT in subarach ranges from 1.5 to 18%, with that higher incidence being demonstrated using prospective lower extremity ultrasound screening in a large cohort study. Poor grade subarachnoid patients appear to have the highest rates of DVT. Measures to prevent DVTs should be employed in all subarachnoid hemorrhage patients. Sequential compression devices are better than stockings and should be routinely used in everyone. The use of low molecular weight heparin or unfractionated heparin for prophylaxis should not be done until you've got the aneurysm secured, but this could potentially be started as early as 24 hours after surgery. The duration it should be carried on for is unknown. Fever, defined as a temp of 38.3 degrees Celsius, is common, occurring in 72% of patients who've had aneurysmal subarach. It's important as fever and cumulative fever burden are independently associated with mortality, functional disability, and cognitive impairment. It's mostly non-infectious, but infection must be sought for and treated. Fever of non-infectious etiology usually starts earlier, i.e. the first 3 days, compared to infectious causes. Intraventricular hemorrhage and poor grade subarachnoid hemorrhage are the biggest risk factors for developing this kind of fever. Patients with intraventricular hemorrhage usually have overall elevated body temperatures rather than having spikes of fever. There are so many potential infectious causes of fever in these patients, but the big ones are catheter-related bloodstream infections and lower respiratory tract infections. Despite prophylactic antibiotics often prescribed for EVDs, ventriculitis is relatively common, and if an EVD is in situ, think of ventriculitis and do regular CSF surveillance. Line infection rates can be reduced by good hand washing, using full barrier precautions during insertion, cleansing the catheter insertion site with chlorhexidine, avoiding femoral sites, removing unnecessary lines, as well as other practices such as biopatches, using antibiotic impregnated catheters, daily chlorhex bathing, gauze dressings, and cleaning the points of access before using them. Reducing ventilator-associated pneumonia is a topic all on its own, but we try to do this in general by reducing the duration of mechanical ventilation, having good oral care, good airway care, perfect positioning, physiotherapy, and early and enteral feeding if possible. So during the acute phase of aneurysmal subarachnoid hemorrhage, if you have a fever, try to aggressively control it and achieve normothermia using standard or advanced temperature modulation systems. Fever and cumulative fever burden are independently associated with worse cognitive outcome in survivors, and improved functional outcome with control of fever has been reported. Pharmacological interventions try to block cerebral prostaglandin E synthesis, lower the hypothalamic set point, and trigger vasodilatation and sweating. They are less effective in brain-injured patients with impaired thermoregulatory mechanisms. Paracetamol and NSAIDs are the first-line therapies to control hypothermia, but the efficacy data is still poor and there are ongoing studies. With physical cooling, fanning, evaporative cooling, ice packs and cooling blankets are relatively ineffective. Surface cooling devices like the Arctic Sun work, but they increase length of stay because you have to sedate people for them to tolerate it. Intravascular cooling devices are even more effective and probably carry no more risk than standard central lines, but are expensive and haven't been shown to improve outcomes. Shivering during physical cooling occurs in 40% of patients and has adverse cerebral and systemic effects that require careful monitoring and prompt treatment. You can try surface counterwarming, buspirone, treating hypomagnesemia, pethidine, and finally sedatives and paralytics. Monitoring of volume status may be beneficial. Certainly, close monitoring of daily fluid balance is essential. Whilst both non-invasive and invasive monitoring technologies are available, no specific modality can be recommended over clinical assessment. CVP-based fluid management is not recommended, and neither is the routine use of pulmonary artery catheters. When choosing fluids, avoid hypotonic fluids such as dextrose or Hartmann's. Suggestion of harm with albumin in traumatic brain injury doesn't exclude its use in aneurysmal subarachnoid hemorrhage. Albumin is an efficient volume expander during the vasospasm phase, but there's no clear evidence of its superiority over crystalloids, and albumin in subarach is still being investigated. So that's the end of another Pecha Kucha. We all want to be good at what we do. After subarachnoid hemorrhage, good ICU housekeeping is what makes all the difference, and awareness of these nuances is one of the reasons why higher volume neuro units get better outcomes. Attention to detail is everything. Thanks for watching.